I'm really excited to introduce our next speaker, Keri Halsema, a legend around the Denver area. We're all going to learn a lot about what is new in our allogeneic stem cell transplant area. So Keri has been a nurse practitioner and senior instructor in the School of Medicine, practicing at the University of Colorado in the Blood Disorders and Cellular Therapies program for quite some time.
Just leave it at that.
Yeah, I think that sounds reasonable. Keri spent a few years doing research on bird brains, which is always a fun fact at a party, just, as a modeling system for learning and memory before earning her BSN and MSN at the University of Pennsylvania back in Philadelphia. Keri started her NP career at the old University of Colorado, all the way downtown on 9th and Colorado, if you remember that location, in the BMT program. And then she spent several years at City of Hope in the hematology and oncology program before she finally came back to the Rockies, to the University of Colorado in 2013. She and several staunch colleagues have built a robust survivorship program for the allotransplant recipient with the Blood Disorders program. She actively contributes to our program's disease-specific committees, developing guidelines and promoting education. And you can catch Keri's Book Corner contributions in AppShow's Advanced Quarterly Electronic Journal. So join me in welcoming Keri.
Thank you very much. Thank you very much. This is kind of top down. Yeah, can I just do this? Yeah. And then
good. And then you can use this, or you can use the keyboard and mouse.
So this goes forward. No, this goes forward. Oh. Okay, I can just do this.
Also use the keyboard arrows.
Okay. And then is there a pointer? No pointers.
No pointer,
okay.
Because it goes. That'll show.
Awesome. Okay. I'll try not to do that too much because I know you're not all cats out there batting at the little pinpoint there. So, oh wait, I want to do. Okay. Arrows it is. There we go. So thank you so much for the introduction. Thanks for having me. My name's Keri, as she said, I'm one of the NPs in the outpatient clinic. And we're going to be talking about what's new in allogeneic stem cell transplant today. So we're going to describe some mechanisms by which post-transplant cytoxin, PT-Cy, as we like to call it, decreases GVHD incidence. We're going to summarize the mechanisms of action of some of these newer graft versus host disease therapies. And we're going to talk about our own personal homegrown strategy here at University of Colorado of dose reducing immunosuppressant agents if one of our patients comes down with COVID and we want to treat them with Paxlovid. Those are my disclosures. And to sort of introduce the entire topic, I think we need to give a little bit of background information on what graft versus host disease is, what the pathophys is, clinical presentation, severity grading, and incidence of it. So the pathophysiology of acute graft versus host disease lies in the fact that the conditioning regimen, radiation, chemotherapy produces these cytokines that activate these host presenting antigen presenting cells, which in turn activate these donor T cells, which in turn activate these helper T cells, which activate these cytotoxic CD4 and CD8 cells, which cause this inflammation and causes sort of rolling cytokine storm. This is in comparison to the pathophysiology of chronic graft versus host disease, where the hallmark of chronic graft versus host disease is fibrosis. And so this gets started with these drug associated molecular pathogens, as well as these cytokines that end up in the cellular milieu, if you'll have it, if you're French and you like that word, promoting inflammation, which causes these this activation of these T cells and dendritic cells, promoting this inflammatory response. This in turn, again, stimulates these helper T cells to be proliferative and produce these cytokines as well. Within the thymus, which typically the primordial T cells go to the thymus, and through a process of both negative and positive selection, T cells that do not recognize, recognize self are the ones that are brought out into the circulation and promote immunotolerance. That negative and positive selection, it goes awry, and these cells do not recognize self from non-self, promoting this alloimmune response. And then this all trickles down to the activation of these fibroblasts, where the cellular matrix is set down and we get fibrosis, along with these plasma cells spitting out all these immunoglobulins, promoting the inflammatory pathway. What this means clinically, for those of you out in our audience here that are not clinical, this has a big impact on clinical presentation. There's a lot of sclerosis that goes on. Patients essentially become encased in their own skin, making it hard to move. You can have a lot of that same sort of fibrotic problems, along with the oral mucosa, impacting dental care, dental health, and nutrition. The esophagus can become fibrotic, making it difficult for patients to swallow food because it gets stuck because of their strictures. Nail changes, eye changes with a very, very dry eye with photosensitivity, and also fibrosis within the lung, potentially leading to lung failure, pulmonary failure. Now, for grading, there's a few different grading scales that are out there. The one that we use is the MAGIC grading scale for acute graft versus host disease, and that's the Mount Sinai Acute Graft versus Host Disease International Consortium scale. And just briefly, a grade 0 means there's no graft versus host disease, up to a grade 4 where there is significant graft versus host disease. Classically, acute graft versus host disease involves skin, liver, and GI tract. Chronic GVHD can affect any organ. And again, there's several scoring systems out there. We use the NIH chronic GVHD scoring system. Mild is self-explanatory, mild graft versus host disease, up to severe graft versus host disease, depending on the severity of the organ involved. Now, we have become our own worst enemies with respect to graft versus host disease because of the success that we've had with allogeneic stem cell transplant. We've been able to transplant patients that are older with many comorbidities. We're able to get patients through transplants that have mismatched donors, so half-matched with a haplo donor, or these mismatched unrelated donors, which typically, historically, have presented with very large incidences of both acute and chronic graft versus host disease. Newer therapies that patients are exposed to prior to undergoing allogeneic stem cell transplant, like checkpoint inhibitors or autologous stem cell transplant exposure, increases the incidence of both acute and chronic graft versus host disease post-transplant. Our patients are living longer. They don't relapse because we're able to give them these post-transplant maintenance therapies. Therefore, the possibility of developing chronic graft versus host disease, it increases because these patients are living longer. And we're also transplanting patients that don't even have a malignancy, such as sickle cell, aplastic anemia, beta thalassemia are some of the non-malignant hematologic issues that can undergo allogeneic stem cell transplant. So this is a timeline of some of these GVHD prophylaxes that have been developed through the years. And I just want to point out that I've been doing this long enough that, as over the past decade and a half, there's been just a plethora of new therapies, new trials, new treatments that have come out for graft versus host disease. And what this timeline tells me is that we're lucky in this day and age because we have lots of smart people out there looking at these molecular mechanisms, coming up with new ways to treat GVHD and get our patients through these complicated therapies. The cumulative incidence of graft versus host disease with respect to acute GVHD because of our ingenuity and our hard work has decreased over time. So up here, back before the year 2000, some of you probably weren't even born then, the likelihood of acute GVHD for all comers was just shy of 50%. More recent development, I think that's a 16% GVHD incidence of acute GVHD in all comers. This graph on the right is a European data from 2017. And again, just to drive home the incidence of acute GVHD, we have a better handle on, but chronic GVHD continues to be quite a problem with 30 to 40% of patients who undergo allogeneic stem cell transplant presenting with some form of chronic graft versus host disease at about 1 year. So what can we do about this? And I know that you listened to Lauren's talk this morning, and I'm kind of tag teaming off of her. And so Gertrude was our patient, right? She's our patient, and she received a haploallogeneic stem cell transplant from her daughter, Hilda. I don't know if Lauren named her Hilda, but I did. And she got thiotepa, busulfan, fludarabine, and post-transplant Cytoxan as her GVHD prophylaxis. Because remember, she has a half-match donor. Her risk traditionally for graft versus host disease, both acute and chronic, is quite high. So what can we do about this? So here's some very familiar drugs to many of our participants today. So the calcineurin inhibitors of tacrolimus and cyclosporin are active here. And what calcineurin inhibitors do, in case you have forgotten, because we don't talk about this in clinic all that much, is that decreases the transcription of IL-2 in T cells and decreases the activity of T cells. So spoiler alert, all of these drugs are going to trickle down and decrease T cell activity. mTOR inhibitors work here, and the mTOR inhibitor blocks the regulation of T cell maturation and proliferation. And when that is blocked, T cell activity is blocked, T cell production is blocked. MMF selectively depletes nucleotides in both B and T cells, therefore decreasing B and T cell activity. And methotrexate is an anti-proliferative drug that cross-links DNA and decreases the lifespan of a T cell. So all these drugs decrease T cells through different mechanisms. And so we come to post-transplant Cytoxan. So if you are a patient with no SIBs, say you got adopted and you're 55 years old and you just got diagnosed with AML, and Dr. Gutman's asking you if you'd like to go through an allogeneic stem cell transplant because you have high-risk AML, but you don't have any siblings, you have no kids, and you have nobody to lean on as a matched related or mismatched related donor, you can dip your toe into the Be the Match donor pool for the National Marrow Donor Program. And if you are of white European descent, the likelihood of you finding a match, an 8 out of 8 match in that pool, is about 75%. So that's not, those are pretty good odds. If you ever go to Las Vegas, those are really good odds, right? But if you're African American and you want an 8 out of 8 match out of that same pool, less than 20% chance of being able to do that. But what if we say you're African American and we are considering a single allele mismatch for you out of that pool? Your likelihood of finding a donor is up to 76%. So just that one allele mismatch really broadens that pool for you to be able to go through a transplant if you have no other related donor to lean on for that. And so one of the strategies that has been popularized and very successful over the past 10 to 15 years is this concept of post-transplant cytoxin. And so what we found is that this has been very effective in allowing us to go forward with these mismatched allogeneic stem cell transplants. And just like Gertrude here, here's Gertrude, our recipient, and here's Hilda, her daughter donor. They are a half match to each other. So traditionally, her risk of both acute and chronic GVHD would be quite high. But what post-transplant cytoxin does is that it's given, you give this induction chemotherapy right here, and at days 3 and 4 post-transplant, you hit them with a slug of cytoxin. And what this does is at that point in time, the donor T cells and the host T cells have reached this crescendo of alloreactivity, and you slam them with some cytoxin, and you kill off a lot of those alloreactive, both donor and host T cells, decreasing that potential inflammatory response. What also happens with this post-transplant cytoxin strategy is it promotes the balance, this upregulation of these regulatory T cells with these effector T cells that still live on even after this post-transplant cytoxin infusion. And down the line, as we talked about the thymus is critical through both positive and negative selection of only allowing T cells to pop out into the circulation that are able to recognize self from non-self. So promoting that that immune friendliness of the environment, if you will. And what the thymus does is it depletes these donors' anti-host T cells. So you only get friendly T cells coming out of the thymus that are circulating later on in the patient's transplant course. So what does this mean with respect to graft versus host disease and relapse? And so what you'll see here, this was a clinical trial looking at tacrolimus here on the left as your standard post-transplant graft versus host disease prophylaxis versus PT-Cy. And in this blue bar, the blue bar is that non-relapsed mortality. So, and that's really similar between these two groups. What that means is that patients are dying at the same rate from infection or being hit by a car, let's say, between both tacrolimus and PT-Cy groups. Acute graft versus host disease is really similar between these two groups. But what the post-transplant cytoxin group has over the tacrolimus group is that relapse with their primary disease is lower in the PT-Cy group, and moderate to severe chronic graft versus host disease is much, much lower in the PT-Cy group. And so those are all really good things, because one of the things that you worry about when you start depleting all this T cell activity is, are you going to then decrease graft versus host disease and decrease graft rejection, but are these patients going to relapse more frequently with their underlying malignancy? And that does not seem to be the case with based on this clinical trial. So we're able to control chronic graft versus host disease pretty well with PT-Cy. What about acute GVHD up front? And, you know, if we're using tacrolimus or sirolimus or cyclosporin, what else can we do to stack the deck in the favor of these patients that are getting these haploallogeneic stem cell transplants? And one of those drugs is abatacept. And so it's been FDA approved for the prophylaxis of acute graft versus host disease. And the way that abatacept works is that it is a ligand to the CTLA, the cytotoxic cytotoxic T cell lymphocyte antigen. I have bad eyesight, 4A. What it does is it promotes this co-inhibitory signal between an antigen presenting cell. So this could be Gertrude cell presenting an antigen to Hilda's T cell to activate Hilda's T cell. When abatacept enters in here, this co-inhibitory pathway is activated and potentially not only decreases T cell induction and activation, but possibly promotes T cell tolerance as well. So let's look at some of the data on that. So this is the ABBA-2 trial, not to be confused. I'd be remiss if I didn't mention the Swedish super pop group ABBA from the 70s and 80s. Their song Dancing Queen is quite an anthem for my own family. So the ABBA-2 trial looked at this mismatched cohort, and what they did is these are patients that received abatacept along with a calcineurin inhibitor, so that's tacrolimus or cyclosporin plus methotrexate, versus these historic controls in this blue line right here from the CIBMTR. And what they found in this cohort of mismatched, single allele mismatched unrelated donors, the risk of cumulative risk of acute graft versus host disease much, much lower in the abatacept arm. That's that orange bar right there compared to historic controls. Not so striking in the 8 out of 8 match, but still better than the historic controls. If you throw in all grades of acute graft versus host disease, the difference is not as striking, but still abatacept in the red line improved incidence, lower incidence of acute graft versus host disease, all grades, versus patients similar to patients in the 8 out of 8 arm. If we look at the 6-month data, with respect to a severe acute graft versus host disease free survival. Again, here on the left, this is that 7 out of 8 mismatch, that one allele mismatched arm, abatacept much very superior compared to those historic controls. Similar findings, but not as dramatic in that 8 out of 8 control arm. And again, remember, when we're decreasing all this T cell activity, we get to be worried about whether relapse of their underlying diagnosis is going to be a problem. That does not seem to be an issue with abatacept because non-relapse mortality, relapse-free survival, and overall survival was superior in the abatacept arm compared to that historic control without abatacept. Now, I know you're like thinking, okay, Keri, we got chronic graft versus host disease under control. We got acute graft versus host disease under control. What if we combine those two? And some smart person decided to do that. And so this was the CAST trial. And what they did is combine both abatacept and post-transplant Cytoxan and gave patients just a short course of tacrolimus. And what they found was the incidence of acute graft versus host disease very, very low. This was a phase 2 trial. There was no comparator arm. And overall survival, graft versus host disease survival, and progression-free survival, all very good on patients treated with this regimen. What's new on the horizon and still under investigation is this ORCA-T therapy. And so instead of manipulating the T cell environment, once the T cells have been infused into the patient, the idea behind this is let's manipulate these cells before they even get to the patient's arm. Okay, and this is described as a high precision cellular therapy biologic, and it's produced by this company called ORCA. I'd like to know why they call themselves Orca, but I don't know. If anybody out there knows, please let me know. And what they've been looking at is giving patients the standard myeloablative conditioning, and then taking those donor T cells and separating them out into 3 separate, really specific populations. Regulatory T cells, which we know now are those good T cells that decrease inflammation and promote tolerance between the donor and the transplant recipient. These hematopoietic stem cells, because you not only need regulatory T cells, right, floating around in your blood, you also need red blood cells and platelets and plasma cells and all those other cells as well. And then these conventional T cells, which are these T cells that are going to be exposed to antigens and become memory cells and help protect you against infection and other foreign invaders. So you need all 3 of those. And so what they do is they give myeloconditioning in a myeloablative conditioning regimen. On day 0, instead of just giving all a big mishmash of cells to the patient, they give these purified regulatory T cells as well as these hematopoietic stem cells. They wait a couple of days because what they want to happen is during this time period, this 48 hours, as these regulatory T cells and these hematopoietic stem cells are running around there in the patient's body, they are creating this very comfortable immune niche for these cells to come on in. So it's a nice, comfortable environment, anti-inflammatory. You could kind of think of it like your grandma's house and she's baking some chocolate chip cookies and she's just waiting for you to arrive and everything's real comfortable and quiet and nice. And then you infuse these conventional T cells. And so that inflammatory response is really blunted at this point. And you give the patient tacrolimus starting on day 3. So let's look at what happens to graft versus host disease in these patients. Well, this is a single arm phase 2 trial. And in the green is the graft versus host disease, and relapse free survival in these patients is really high, meaning no GVHD and really high survival rate in the patients that receive these Orca T products compared to standard of care, where the patients just received the donor stem cells without any sort of cell separation. And all comers with patients that received all the Orca T product, high graft versus host disease, relapse-free survival as well. So GVHD seems to be well controlled. Patients seem to be living long, even with this product. And so if we look at longer data going out, we see that relapse-free survival is 77% in those patients that receive that Orca T cellular product versus the patients that received just the standard stem cell infusion with PT-Cy. Non-relapse mortality was very low in that Orca T population as well compared to the PT-Cy group. 3% versus 16%. Overall survival, very, very high in that Orca T population, 94% versus 77%. So a good, really intriguing idea, something to think about, not commercially available. They're doing lots of clinical trials on this, and I think this sounds very, very interesting going forward. So we have all these things that we can do to protect our patients from developing acute or chronic graft versus host disease, and also stack that deck in favor of them living longer. What about our patients that present with graft versus host disease? So here comes Gertrude, 6 months after her transplant. She walks into your clinic. She's got terrible scleroderma, very dry eyes. Her mouth is killing her. She's not been able to eat, and she can't even lift her arms over her head because her fasciitis is so bad and her tendons are so thickened from the graft versus host disease. What are we going to do for her? So there are 3 graft versus, there are 3 medications that have been approved for chronic graft versus host disease. Ibrutinib is one of those. It's a BTK inhibitor, and the way that it works is it blocks the signal, those inflammatory signals found on both B cell and T cell receptors, decreasing B cell and T cell activity. Belumosudil is a ROCK2 inhibitor, and the ROCK pathway tends to increase inflammation and decrease T cell regulatory T cell upregulation when exposed to growth factor cytokines or integrins. So when you block ROCK2 with belumosudil, T cells, regulatory T cells are upregulated, fibrosis is decreased. And with ruxolitinib, ruxolitinib blocks the JAK1 and JAK2 pathways, thereby blocking the inflammatory signals caused by interferons and interleukins on these T cells, and also decreases in the fibrotic pathway, as well as upregulating the T cells. So belumosudil, ruxolitinib, upregulation of Tregs and decrease of fibrosis. Ibrutinib decreases cytokine production, therefore decreasing inflammation. So if we look at ibrutinib for treatment of graft versus host disease, it was one of the first approved for GVHD, for the treatment of chronic graft versus host disease in patients that had failed at least one line of prior therapy. This was a small clinical trial, but interestingly enough, this clinical trial made a point of including patients that had active chronic graft versus host disease on at least 25% of their body surface area, as well as inflammation of the mouth, involvement of the mouth. And what they found is that the overall response rate in these patients was 67% in these patients that had failed other therapies. If we look at responders versus non-responders in steroid doses, steroids are great in the short term, but have a lot of long-term side effects, as those who treat patients with steroids are very familiar with. And what's important is that if you're able to get those patients on lower doses of steroids, that is better overall for the patient. And that's what they found in this ibrutinib group. As the weeks went on and these patients that responded to ibrutinib, we were able to lower the dose of those steroids, therefore decreasing the toxicity associated with that long-term steroid exposure. And then looking at ibrutinib at that 2-year mark, we see that the best overall response was maintained at 69%. So patients that responded continued to respond long-term. They didn't lose that response. Failure-free survival wasn't too bad at 51%. In treated patients, 43% of those patients had improvement in their Lee symptom score. So those of you who are not familiar with the Lee symptom score, that's a symptom score looking at chronic graft versus host disease symptoms for the patient. So it focuses on being able to chew your food well because your mouth doesn't hurt. Are you? It has questions on looking at whether you're short of breath. Are you happy in your life, and those other psychosocial criteria as well. And the safety profile with ibrutinib over the long haul was also very good. So this is a good drug to use for graft versus host disease because the response is sustained. But let's look at Rezurock, belumosudil for chronic GVHD, and this was the Rockstar trial. And we see that belumosudil, this is kind of a busy slide, all comers, all patients who had received belumosudil as treatment for chronic graft versus host disease, about 77% of them had a response to the belumosudil. And if you want to slice and dice this patient population into different fractions, those patients who had multiple organs involved, more than 4 organs involved with their chronic graft versus host disease, also had a good response at 72%. Patients that had prior ibrutinib or ruxolitinib exposure also had very good response at 74 and 66%. So patients that didn't respond to previous therapies tended to respond to belumosudil. If we look at that 3-year follow-up with belumosudil, the overall response rate in this patient was maintained in that 74, 75, 76% status as well. So this is a good drug. It's effective in about 70% of those patients, and that response was sustained even long term. If we look at ruxolitinib for treatment of chronic graft-versus-host disease, this is a much bigger trial looking at about 330 patients. And these are patients that were also steroid refractory to their GVHD treatment at 24 weeks, which is about 6 months. About 50% of the patients responded to ruxolitinib compared to best available therapy as determined by the investigator. If we look at long-term data, what the ruxolitinib folks did is that they allowed these patients that were in this best available therapy arm to cross over to receive ruxolitinib. And at the time of crossover, that response rate was about 50%. But what happens during this crossover period, those patients that had not seen ruxolitinib also gained a response, and the best overall response during this crossover period was about 80%. This response was maintained. This duration of response was not reached at 3 years in the ruxolitinib arm compared to a little over 6 months in the best available therapy arm. And again, that overall survival was about 6 months in the best available arm and about 38 months in the ruxolitinib arm. So again, another drug that we can use to treat these patients that treats chronic graft-versus-host disease very effectively without negatively impacting their overall survival. There's a new drug that is not yet commercially available, but we're excited to use in our treatment of our patients, is axatilimab. And it's based on this study, the AGAVE study that was recently published last December. And axatilimab is a monoclonal antibody. It's first in class of this anti-CSF1R colony stimulating factor 1 receptor antibody. And what it does is it binds to these pro-fibrotic macrophages and these inflammatory macrophages, decreasing the fibroblasts being activated, and fibrosis is decreased, as well as decreasing those inflammatory cytokines. And if we look at this AGAVE trial, the primary endpoint in this trial was looking at 3 different dosing regimens with axatilimab, and looking at the primary endpoint of overall response rate in those patients during the right after the first 6 cycles of axatilimab. Secondary endpoints, again, was improvement in this Lee symptom score, as well as organ-specific response rates and duration of response. Patients could be on corticosteroids, calcineurin inhibitors, or mTOR inhibitors, but no other therapies were allowed on this trial. And when we look at the 3 different dosages looked at in this trial, the dose at 0.3 milligrams per kilogram given IV every 2 weeks had the best overall response compared to the other 2 dose levels, with a overall response rate of 74% in these patients after just 6 treatment months of axatilimab. So that seems to be a very good response in these patients. And if we break it down with the different organs that are involved, dark blue is the complete response, light blue is a partial response. All different organ systems responded to axatilimab. But in particular, what's most difficult to treat in these patients is this scleroderma presentation of chronic graft versus host disease. And while it's not stellar that 27% of patients had some sort of response to axatilimab, that is quite a big step up from other therapies that are currently available. So this is a good option to try in these patients that have real stubborn sclerodermatous changes of their skin. So we're going to switch now, and I bet I'm way over time. Am I? Everybody? So we're going to talk about infectious therapies and prophylaxis. I don't need to tell you that COVID-19 has been at the forefront of many of our brains for the past several years. And the COVID-19 vaccine has been critical in helping us, in many people's opinion, helping us fight this pandemic. It is a relatively novel type of vaccine that's out on the market. mRNA vaccines are made when a little piece of mRNA that is tagged to one of the spike proteins on the COVID-19 molecule on the COVID-19 virus gets incorporated into our own DNA, and therefore we're able to recognize the COVID-19 virus, as opposed to traditional viral production, where an attenuated piece of the virus is introduced into the patient's body through a vaccine, and through our own natural ability to recognize these antigens, we're able to recognize these viruses and fight them off. So the COVID-19 vaccine was this new type of vaccine that corresponds to the COVID-19 virus. The RSV vaccine was just approved last year. Anyone over the age of 70 is eligible to get it. And those patients who are at increased risk, so that would be our allogeneic stem cell transplant patients, as well as patients undergoing chemotherapy overall. If you're over the age of 60, you're able to get it. At this point, the RSV vaccine is not an annual vaccine. Just to sort of highlight how important the COVID-19 pandemic and any treatment to decrease the fallout from it is, based on the CDC website, just under 2 million people died here in the United States between January 1st of 2020 through July 31st of this year. With respect to patients that were undergoing allogeneic stem cell transplant, the mortality of those patients that became infected with COVID-19 was about 21% between January 2020 and March of 2022. So a significant issue in our patients that are immunosuppressed, like our stem cell transplant patients. And we have a drug that was granted emergency use authorization in December of 2021 called Paxlovid. So it's a combination of two different antivirals, nirmatrelvir and ritonavir, and we use it quite a lot in our clinical practice when our patients call in and tell us that they're COVID positive. It decreases hospitalizations and risk of death in patients that are infected with the COVID-19 compared to placebo. And so it has a strong track record, and we use it quite a lot. We also know that Paxlovid has many, many drug interactions, and you have to be a little bit careful about this when you're prescribing this for a patient. Patients that are on those direct oral anticoagulants, like help me here. Xarelto and Eliquis. If they're on a DOAC, that DOAC, if they're on full dose DOAC, we need to cut that DOAC dose in half. If they're on a half dose for prophylaxis, we have to hold that. Statins need to be held, except for rosuvastatin, which is also our favorite statin because it's metabolized through a different pathway. Azoles have to be held. So if somebody's on fluconazole, voriconazole, whatnot, those need to be held while the patient is receiving Paxlovid. Or older gentlemen that use Flomax for their BPH, that also has to be held. And immunosuppressant therapy. So we get a lot of patients that are still on tacrolimus, cyclosporin, sirolimus call in and say that they are COVID positive, and we want to use Paxlovid for these patients. In the package insert, it tells you that you need to hold these medications because of the drug-drug interaction can cause huge spikes in the levels of these immunosuppressants, putting the patient at toxicity from those immunosuppressants. And so what we've done, and this has not been published, and we may think about doing that ourselves, is we have the patient hold their immunosuppressant when they start their Paxlovid. If they're local to us or if they're local to a UC Health facility, we have them come in, we have them check a cyclosporin level on day 3, and we see where it is. A therapeutic cyclosporin level is somewhere around 200 to 300. And if they walk in on day 3 and their cyclosporin level's 50, that's a little bit low for somebody who just went through an allogeneic stem cell transplant. And what we've found is that if we give them just a little dose of cyclosporin, like 50 milligrams, just a one-time dose of 50 milligrams of cyclosporin, they come back on day 5 or 6 of their Paxlovid. We draw their cyclosporin level, and lo and behold, their cyclosporin level's 150 to 250 with just that one little bump of cyclosporin sort of mid-Paxlovid therapy. And so what we do, and that's kind of what we've done for tacrolimus and sirolimus as well, and it seems to have worked out. The N number is very low. We have only done this in a few patients, but it seems to work out very, very well for us. So that's a little clinical pearl for all of you folks out there. What if somebody's on a DOAC or a medication that you can't get them off of, like some sort of antifungal because they've got a huge fungal ball sitting in their lungs? Well, there's another drug called remdesivir that you can use. It's not as easy to use as Paxlovid because it's IV. You got to find some place to give that to them. It was FDA approved in 2020. And for non-hospitalized patients, you can give it IV consecutively over 3 days. And we have a place here in the University of Colorado system where we can give it. And it can also be given to patients that are ventilated and really sick in the hospital that can't take an oral medication. So that's been real helpful. CMV, this used to be, for those of us who've been in the transplant game for a long time, has what used to be a real terrible, terrible, terrible thing, causing a lot of morbidity and mortality in the post-transplant patient. But with the ability to survey CMV reactivation by PCR, we're able to pick up on CMV reactivation early and intervene early. CMV is a herpes virus. By the age of 6, about 60% of the American population is seropositive because you just pick it up and it's just transmitted by the usual bodily fluids that we're all familiar with. This primary infection presents usually as an upper respiratory type infection. The CMV lays dormant in these myeloid cells for years and years and years. And when you decrease cytotoxic T cell replication and activity like you would in a post-allogeneic stem cell transplant, that's when the CMV begins to replicate because those cytotoxic T cells are key to keep this CMV level low. And so in 2017, the FDA approved a new antiviral called letermovir for the prophylaxis of CMV in these patients that have undergone allogeneic stem cell transplant. Letermovir works by inhibiting this enzyme that packages up the DNA for CMV, and therefore CMV maturation is interrupted and cannot replicate. The typical dose dose for letermovir is 480 milligrams orally once daily, unless you're on cyclosporin, and then you decrease the dose to it's 480. 480 once a day. And if you're on cyclosporin, you want to decrease the dose to 240 milligrams once a day because of the drug interaction. And this has been very effective with CMV prophylaxis. Maribavir is a newer antiviral medication for those patients who present with CMV reactivation that seems to be resistant to our usual standard of ganciclovir or valganciclovir. And so it is an oral medication that can be given to these patients that seem to be resistant to our standard oral and IV antivirals to treat CMV. And I'm going to end with C. diff. So C. diff is this anaerobic gram-positive spore-forming bacillus. It can be colonized in the intestinal tract. So in about 30 to 40% of us sitting in this room were colonized with it. When patients are carriers of C. diff, you don't have to be actively having a C. diff colitis flare in order to spread C. diff. Just having C. diff, you are a carrier of it, and you can leave those C. diff spores on tables and chairs and door handles and whatnot to be picked up by your colleagues walking down the hallway. So again, wash your hands. This is a public service announcement for that. And what happens is that when C. diff in its vegetative state is the bacteria is decreased in the GI tract after exposure to oral antibiotics, those spores persist in the GI tract and start producing these toxins that your GI tract does not like, and you begin to get diarrhea. And so this is a big problem for a hefty portion of our post-transplant population. And so again, if you're old enough like me, all we had back in the day was Flagyl, metronidazole, and that's all there was, and that's all you had. About 25 years ago, oral vancomycin came on the market, and it was like, it was just like so much more effective than the Flagyl was, and we used that for quite a while. In 2011, the FDA approved a new macrolide antibiotic called fidaxomicin, which has proven to be more effective than the oral vancomycin and is now the preferred agent based on the newest IDSA guidelines. And that's been quite effective in treating our patients for the C. diff. And fecal transplant. I remember when my friends who works here in infectious diseases started talking to me about fecal transplant. I could not believe that we were doing this, but it's effective because you're repopulating the patient's GI tract with that good flora from somebody else. And we also have bezlotoxumab, which is this monoclonal antibody that can be given once, generally in the outpatient clinic, because that's where it's paid for, that decreases that toxin in the GI tract and really gives the patient almost immediately relief of their C. diff symptoms of diarrhea and cramping and all of that. In addition, what's been found is that patients who've been given bezlotoxumab have fewer recurrences of C. diff colitis going forward. So that, I think, is that.
Thanks, Keri. I'll open up to any questions.
Oh, you got it.
I was really excited about that ORCA trial. That's pretty cool.
Mm-hmm.
Or product or process,
Mm-hmm.
whatever you want to call it.
Mm-hmm.
Is that available for all donor types? Like, can you do that with cord blood donor as well? Or,
No idea.
oh, okay. Okay. Just
It's only
curious.
been done with
Okay.
adults at this
Okay.
point, but that's a good
Yeah.
point. I didn't even think about that.
Yeah. I
Yeah.
was just wondering about
Yeah.
volumes. Yeah.
The data on the Orca website is not very telling.
Okay.
Yeah, doesn't have a ton of information. It's all secret.
Just like their name.
Are we there? Okay. Keri, thanks. That was a really excellent talk as usual. Lots of great information. What, in your mind, what is the most exciting thing? You see these chronic graft versus host disease patients all the time out in clinic. What are you most excited about in thinking about how you manage your patients now and in the future?
Anything that will decrease that fibrosis. I saw one of our long-term patients just on Monday, and she is just literally encased in her own skin, and it's terrible. And you sit there and you think, we've cured your leukemia, and I'm really pretty darn sure, I hope to God, that your leukemia is not about, there's no way your leukemia can come back because you've got such a robust immune response against you that there's no way any primordial lurking leukemia cell would ever survive that. But on the flip side, her life is miserable, absolutely miserable. So anything that can do that. Also, I think 20 years ago, we were kind of the mindset that you could only use one drug at one time. And we don't do that anymore. We combined these drugs because they work through different mechanisms. And hopefully the gestalt of all of that allows these patients, gives an even better pop with respect to their GVHD treatment.
Yeah, the skin GVHD stuff is so, it's disfiguring, it's demoralizing, it's all of those things that, some of our patients have to go through. And then you think about the chronic GVHD that kills patients, which is pulmonary and GI GVHD, probably more so than.
That kills them quick. It kills them quicker.
Yeah. What for pulmonary GVHD again, which is, is what many patients die of, in addition to, of course, just infectious complications related to all their immunosuppression. What of all these drugs, what is, I'm sorry, I may have missed it, but what is the kind of the best drug we have right now for pulmonary GVHD? Are we just not?
Nothing
yet?
stands out at this point. Yeah.
It's getting that combination of multiple drugs probably that gives us a chance. And then I guess transplant, pulmonary transplant.
I've never done that. I've never sent anybody for a lung transplant.
Yeah, it's not a good situation because, I mean, it's hard to find a patient like that can withstand that when that's severe of GVHD. But